Now we have the honor of having Dr. Brian Rini here from Vanderbilt University. He's a GU oncologist, the director of their clinical research program, and also I'm a big fan of his unbelievable podcast. He's one of the Euromigos, which probably is, I would say, the best podcast in oncology out there. So thank you, Brian.
All right, thank you, Brad. I appreciate it. I swear I didn't pay him to say that. I mean, it is the best podcast, but I didn't pay him to say that. So it's really great to be here. I'm going to talk today about both adjuvant and frontline kidney cancer, and I don't have that long, so I'll try to buckle up and get through it here. So in the adjuvant setting, historically, as you know, nothing's really worked in kidney cancer, decades of negative trials. Sunitinib's approved but not used because of toxicity. And so basically observation's been the standard of care regardless of risk after resection of high-risk kidney cancer. And then the Keynote study came along, first presented and published last year and updated at ASCO GU this year. This was a trial that took, as you can see, intermediate high risk, and then resected M1 disease, which was a special subset, and randomized them to a year of pembrolizumab or a year of placebo. And you can see some of the stratification factors, and the primary endpoint was disease-free survival per investigator, and of course, looking at overall survival. And so what you see here on this split screen is the initial analysis at 2 years of follow-up and this updated analysis with just 6 more months of follow-up, so not a whole lot more events or follow-up. You can see the numbers down on the bottom there. But what we see is a consistent benefit for adjuvant pembro versus placebo in this setting. Hazard ratios now dropped to about 0.63 significant, and the curves, as they mature, are staying apart. And so I think one of the questions in the adjuvant, any adjuvant setting, including kidney cancer, is about, are we just delaying progression? Let's put aside overall survival benefit. Are we just delaying progression, or are we actually preventing it in a subset of patients? And to me, that's a very different benefit that you might explain to a patient. We don't know that yet. That's going to take many more years of follow-up. But as you see these curves start to split and presumably stay split, I think that's a question that will come up. An interesting bit of data that I don't think was presented at the first presentation or even in the publication was sarcomatoid status. So as you may know, sarcomatoid is a growth factor that occurs across histologic subtypes of kidney cancer. It's particularly aggressive, particularly inflammatory, particularly non-VEGF responsive, but particularly immune responsive. And so when they looked in this sarcomatoid subset, and you can see it was about 100 patients. If you look at the number at risk on the bottom right there, the 100 patients with sarcomatoid features, that hazard ratio goes down. Now, it's a subset. There's large confidence intervals, so don't take too much away from it. But to me, when I use this agent in the clinic, this is one feature that might drive me to use it. Higher risk, higher T-score, nodal positivity, and sarcomatoid features, I think, is probably a good selection factor as well. Here are the overall survival curves. Again, initial and then updated. They don't look much different. Hazard ratio is consistent. You can see there's a ton of censored data here. Remember, the median time to recurrence of even high-risk kidney cancer is 5 years. And even in high risk, many of those patients won't recur, so their survival is not affected. So we'll see if there's a survival advantage shown. That hazard ratio looks nice and low, but again, it's early days. I think may be difficult to show a survival advantage. And I think one of the factors, again, in any adjuvant setting that people think about is, is disease-free survival advantage enough? Putting aside the cure fraction question, is disease-free survival enough? Regulatory-wise in the US, it hasn't required survival. In other countries, it may. And so we'll see how these data mature. But I think at least, again, very fewer number of added events here in this updated analysis. It was only 6 months, but the data at least consistent to this point. So that's the adjuvant setting. I guess I would just back up and say I do use adjuvant pembro in clinic. I tend to apply it to the higher risk patients who would have entered the Keynote study. So sarcomatoid patients, high-grade T3, certainly node positive, resected metastatic disease. In patients who are T2 high-grade, which has about a 20% risk of recurrence, I certainly have a discussion with the patient. I didn't present adverse event slides here in the interest of time, but as you know, adjuvant pembro generally well tolerated, but there's going to be a subset of patients who have rare, potentially serious, and potentially lifelong effects. So I think this will evolve over time. And the last thing to mention is this is just the first of 5 adjuvant immune therapy trials in kidney cancer. There's a litany of them. I think the next one, adjuvant Atezo, will probably be reported by the end of this year, and then there's others to follow after that. So this is just the beginning of the story. So turning now to systemic therapy in kidney cancer. So this is, the obligatory timeline slide you see in these talks. And really just to say that, when I was finishing fellowship in the late 90s, it was just high-dose IL-2 that was approved in RCC. We entered an era of VEGF TKI monotherapy with good tumor shrinkage, reasonable response rate, but still not curing patients. And then when checkpoint inhibitors came online many years ago, it was initially single-agent nivolumab in a refractory setting. That was its initial approval, and then very rapidly into the IO combo era. And I'll talk about sort of summary high-level data. And you can see on the bottom, the median survival has gone from 1 year in the old cytokine era to now about 5 years. I'll show you the updated Ipi-Nivo data with median survivals that are almost 5 years. These are data from a publication that came from the Emotion 151 study. So that was a study of atezolizumab plus bevacizumab versus sunitinib. You've not heard much about it because there was only a PFS, not an OS benefit, and Genentech Roche never filed the data for approval. So it's not an FDA-approved regimen. The best thing to come from that was a correlate effort, to their credit for doing a large correlate effort from, in essence, a negative trial. And these data were published in Cancer Cell, I guess, 2 summers ago. And really what it did, about 900 patient samples, mostly nephrectomy, RNA sequencing, full transcriptomic sequencing on all these tumors, and based on that sequencing, segregated patients into these biologic clusters. I'm going to talk a little more about this at the end, and I don't want to belabor it, but it really just makes the point that most of kidney cancer is either angiogenic driven, cluster 1 and 2 in this data set, or immune pathway driven. And that was cluster 4, 5, and probably 7. So it's not surprising that all the drugs I'll talk about, all the drugs that are approved are either anti-angiogenic or pro-inflammatory, if you will. They're checkpoint inhibitors. Cluster 3 and 6 are probably driven by a bunch of different pathways that we don't yet have therapeutic drugs for. So this is Ipi-Nivo. It's titled IO plus IO because we commonly refer to it by that moniker. First presented and published, 3, 4, 5 years ago. And as you're familiar with now, it's Ipi-Nivo induction up to 4 doses, then maintenance Nivo. All the phase 3 trials recently in kidney cancer used sunitinib 54/2 as a control, which was the old standard of care. And then the other main trials are IO-TKI trials. So this is a mechanistic slide that says, why would we combine VEGF inhibition with checkpoint inhibitors? And frankly, a lot of it is just a clinical combination, right? That's what we do in oncology. And you just saw some prostate data combining, AbbVie with a PARP inhibitor, right? Mechanistically, we can find some rationale for it, but a lot of it is just clinical combinations. That's how we cure patients with advanced solid tumors. On this slide is that mechanistic rationale, basically saying that VEGF is an immunosuppressive molecule, and it has effects on dendritic cell maturation, immunosuppressive cells like myeloid-derived suppressor cells or regulatory T cells, et cetera. And therefore, when you inhibit VEGF, when you suppress it with either an antibody or a TKI, you allow the immune therapy to work better. And this is just a schematic from a review, but there are actually a couple decades of work to suggest this is the case. This is hard to measure in patients, and whether there's an additive or a truly synergistic effect from the combos is probably open to debate. And there were 5 such IO-TKI studies. I mentioned one of them, atezo-bev, another axivalimab that also has only had a PFS benefit. So listed here are the 3 studies that have led to an overall survival benefit in frontline kidney cancer. And you can see these trials were broadly similar. Top to bottom are actually in reverse chronological order. All have a sunitinib control, all large frontline trials in previously untreated kidney cancer, similar endpoints. So while there are subtle differences between the trials, I think they're broadly considered similar, and we commonly refer to the combinations as len-pembro, cabo-nivo, and axi-pembro. And this is just a summary slide that I updated after ASCO GU, because there's a lot of data here. I'm not going to drill down into all the data sets, but you can see the hazard ratio for survival, now fairly mature and updated, is remarkably consistent across these regimens. Whether it's 2 immune drugs or an immune and a VEGF drug and different combinations and partners, 0.7-ish is the hazard ratio. The medians are fairly immature for the IO-TKI regimens. So I'll focus on the medians when I get to the Ipi-Nivo data. Some landmark data there. I think further out landmark will probably be more important. One thing you do see here, if you look at hazard ratios for PFS, response rates, and CR rates, is that the IO-TKI regimens give you more tumor shrinkage, right? Not surprisingly, because you have that VEGF suppression component there. You get higher tumor shrinkage, you get less early progression. And so one way to choose among these regimens, they're all FDA approved and used. In patients who have more bulky symptomatic disease, providers will generally choose an IO-TKI regimen. choosing among these different IOTKI regimens we could spend an hour on and argue back and forth, and I could probably pick any one of these and defend it in a debate. And it really just comes down to dealer's choice. Familiarity with the TKI partner, experience with the regimen, knowing how to use it, just like any oncology regimen, I think is probably the most important. And then that bottom row there, that landmark PFS, I think is going to become more important as all these data sets mature over time. You see the number of 30% for Ipi/Nivo at 5 years. That trial happened first. The others were 2+ years behind, so the landmarks are less mature. But if you think about it, if you're starting a patient on Ipi/Nivo today, you can say to that patient, there's about a 1 in 3 chance that you'll be alive with controlled disease in 5 years, right? We'd love that number to be higher, but it's not bad. It's certainly much better than historical controls. And again, whether the IOTKI regimens will have that long-term durability is yet to be seen. Just a word about IMDC. We talk about these prognostic criteria a lot. So these stand for International Metastatic Database Consortium. Danny Hang, who was actually a fellow at Cleveland Clinic a long time ago, developed these prognostic criteria, which are now the most commonly used. They were developed in a set of patients who were receiving VEGF-targeted monotherapy. You can see the factors on the left there. And so patients who are favorable risk, by definition, have either slow-growing disease, naturally, which happens in kidney cancer, or they have VEGF-responsive disease, right, because they did well in this data set. So when you say favorable risk, you're saying that these patients are VEGF-responsive. Now, I'm going to show you data later to contradict that, to say it's not true for every single favorable risk patient, but in broad strokes, that's true. So it's not surprising that we see some of the results in these subsets with these regimens that we do. And this is that slide to refute that. So this is back to that biologic data set of the clusters, the one cluster slide that I showed you. And it looks at 2 different common clinical risk groupings, the IMDC on the right and the Old Memorial on the left. And if you just look at the columns, a favorable risk column, what you see there is that it's very heterogeneous. So when we classify patients just by clinical risk factors, we're missing a lot of biologic detail. You can see favorable risk if you look at that IMDC column there, the first of that second set of columns. The top 2 colors there are the angiogenic clusters, so it's about 60% of patients. So yes, most favorable risk are angiogenic driven, but on the other side, 40% are not. And so if we design trials just based on these clinical risk factors, we're missing a lot of granularity there, and we really need to do better to personalize therapy. So just a little bit into the data. So these are the updated Ipi/Nivo data. This is called a 5-year update. So you can see the overall survival, the Ipi/Nivo is 55.7 months, so that's the not quite 5-year that I was quoting. And then the progression-free survival curve on the right, you see that 30% mark that was on the table. And that's really the landmark PFS at 5 years that the other, all regimens will be compared to moving forward. Now, again, it's not to, in immune therapy, we talk a lot about the tail of the curve. It's not to ignore the first part of the curve, which is important, right? All parts are important because they all represent patients. But if we're talking about durable effect, I think this is going to be the number to beat, right? This is the number on the board to beat. It's 30% progression-free at 5 years. This is favorable risk, which looks very different, right? Because it's mostly, but not exclusively, VEGF-driven. So no survival difference. Those patients do better in general. Those medians are higher because they have more indolent disease. And actually, sunitinib has better progression-free survival and better response rates than Ipi/Nivo in this setting. So again, when this was the first data set out before the IOTKIs, Ipi/Nivo was used in intermediate and poor. That's its FDA approval, and sunitinib was still used in favorable risk. And these are just some of the response rates and duration of response. I won't belabor that. I'll just go over one of the IOTKI regimens in the interest of time. This is the Axi/Pembro data set, Keynote 426. And I'm bringing it up not so much for the absolute data, which I showed in that table, but because in Merck's development program, they stopped pembrolizumab at 35 doses or 2 years. That's that large green line at 24 months, obviously. And what we don't know with any immune-containing regimen is the proper duration of therapy, right? It's a big question in oncology. How long do we need to continue immune therapy? In theory, if we generate an anti-tumor immune response that it's in a patient, it should persist, right? Just like a vaccination response should persist. But we haven't really studied it carefully. It's very difficult to study. So to Merck's credit, they stopped Pembro at 2 years in this study. I have no idea where 2 years came from. I think it was an arbitrary decision. But at least in this data set, which is about a year more mature than that 2-year mark, it doesn't look like these PFS curves come together, right? If you look at the landmarks and the difference between them, it's about 13 or 14% that persists out to 3 years. So it's not a lot of follow-up after that 2-year mark. It's approximately a year. But it's at least somewhat reassuring that if you're using this regimen, that you can stop pembro at 2 years. In fact, you could probably stop it earlier. There's no data. And it's probably individualized, but at least on the broad scale, I think it provides some reassurance. And this is same data, but it was presented actually at ASCO GU a year ago. It's just looking at specifically the cohort of patients who did stop at 2 years, which was about 25% of patients. Again, looking at survival and progression-free survival. And short summary is, again, these patients don't drop off. They don't rapidly progress and die after stopping pembrolizumab, as you would expect, right? Anybody who's been on 2 years is quite obviously doing well, has generated an anti-tumor immune response that seems to persist. Just a note about toxicity. Again, I don't have time to go over all the toxicity, but I think if we think about toxicity to now frontline doublets in kidney cancer, you have Ipi/Nivo on the left, and that spike you see is sort of that upfront inflammatory toxicity of skin and gut and liver and et cetera. But once patients get through that, if they can get through it, they tend to do quite well. I think aside from sort of arthralgias with long-term maintenance Nivo, I think patients actually tolerate maintenance Nivo quite well. On the right is just sunitinib monotherapy, but I think it's emblematic of the IO-TKI regimens, meaning it's more spread out, right? Those curves, there's a little bit of a spike in the beginning, but it kind of persists. So when you have a TKI in your regimen, you're sort of saddled with some of that chronic toxicity. Now, how long does the TKI need to be continued? It's an open question. My personal opinion, based on absolutely no data, is that it's way more important up front for that tumor shrinkage, and then the immune therapy takes over. Again, I don't have any data to show that. But it's just really showing you graphically. I like this because it kind of shows graphically the upfront inflammatory toxicity versus the more chronic toxicity for the TKI-containing regimens. Another feature that sort of differentiates these regimens is the ability for disease control off therapy. So this is called treatment-free survival. My friend and colleague Dave McDermott and Meredith Reagan have done a lot of work in this area. And there was actually a recent clinical cancer research paper on the Ipi/Nivo data, really characterizing this treatment-free survival. What this means is the patient's alive with disease control, but their drugs have been stopped, usually for toxicity. And this is actually an old slide, but it shows about 20% of people out at 2 years who are, again, alive with disease control, but off therapy. And this is what you want as a patient, right? If you could ideally get therapy up front, tolerate it, have your tumor shrink or go away, and then be able to remove the therapy, that would be ideal. And it's an argument for an all-immune regimen. We're working with FDA to analyze this kind of data, these kind of data in the 3 IO-TKI trials. We don't have anything yet, but I think that'll be another sort of way to differentiate among these regimens. I mentioned sarcomatoid in the adjuvant setting as particularly immune responsive. These are subsets from some of the trials I mentioned. Ipi/Nivo on the left is the most impressive, maybe not surprisingly, right, because it's 2 immune drugs. And if you look at just at that top line, the response rate goes from 40% in all comers to 60% in the sarcomatoid subset. The CR rate goes from about 12% to here 19%. We're actually going to update these data at ASCO. The updated CR rate is 23%. So some people have used this to say, well, gee, if I have a metastatic patient with sarcomatoid features, then I'm preferentially going to choose Ipi/Nivo. I do the same thing. I think it's perfectly reasonable. And this is just a summary slide of IO versus IO-TKI, right? 4 regimens that extend survival in kidney cancer. It's a good problem to have. I won't read this to you, but it's really a dealer's choice. And some people lean, I tend to use IO-TKIs generally, but IO in a young, fit sarcomatoid patient for sure. Obviously, they need to be able to tolerate Ipi, which many kidney cancer patients can't. And then you can read some of the other pros and cons there. And that's really what this slide sort of represents the last 5 years of kidney cancer, right? We now have 4 survival extending regimens, and we can argue all day about regimen A versus regimen B. I don't think that's particularly productive, so I think we've sort of moved on from that, but these are just some of the pros and cons. So how do I choose frontline therapy? Again, I've mentioned some of this. I tend to use IO-TKIs, just familiarity, ease of use across risk groups and across patients. I didn't talk too much about side effects, but when you have a TKI in your regimen, you have the ability to sort of withdraw that, and especially with a short half-life TKI, let the toxicity resolve quickly. It allows you to differentiate what specific drug is causing toxicity. I didn't talk about IO monotherapy. That's probably a whole separate talk. I'd love to be able to give it to a select biomarker, selected subgroup of patients, but we don't know what that biomarker is because that would be the best, right? If you can just get IO monotherapy and have disease control, that's the best. But PD-L1 has been unreliable in kidney cancer, much like bladder cancer. And the bottom line there, you just heard triplet data in prostate cancer. That's where we're headed in kidney cancer. Obviously, all these axes, all these pathways are important, VEGF, PD-1, and CTLA-4. There is a trial called COSMIC, which is Ipi/Nivo plus minus Cabo that should be out this year. Merck's also doing a big frontline triplet study with a similar arm and also using their HIF inhibitor. So as mentioned, that's, in oncology, the way to cure patients is to put non-overlapping mechanisms of action together. Whether those will be tolerated, whether they will apply to all patients, I think we're starting to have that discussion in prostate cancer, and we're certainly headed there in kidney cancer. This is that COSMIC study. Again, it's just Ipi/Nivo plus minus cabozantinib. It's accrued. I believe, I'm not part of it, but I believe it'll be reported this year. You can imagine toxicity could be an issue. If you've given Ipi/Nivo and you've given Cabo, they're independently toxic. So we'll see how these data turn out. And this is just the Merck study I mentioned. The wrinkle here is the HIF inhibitor belzutifan, which is approved in von Hippel-Lindau syndrome, not yet in sporadic kidney cancer, and this trial is accruing. But just sort of an example of where the field is heading. And then lastly, by way of advertising, this is we're doing a trial at Vanderbilt called Optic, and basically we're using that, that cluster data to assign patients treatment. So we're going to take patients, biopsy a metastatic site, determine their cluster. If they're in an angiogenic cluster, which is 1 and 2, we'll give them a TKI-containing regimen. If they're in 4, 5, 7, which I described as inflammatory, we'll give them Ipi/Nivo. Cluster 3 and 6 actually aren't part of this trial because they're probably driven by other things. But if we can actually do this, if we can get this off the ground and do it, which is a big if, we view this sort of as a platform to test novel drugs in the future and myeloid drugs or other drugs, in pipelines. So just to wrap up, kidney cancer it's angiogenic and inflammatory. It's responsive to both of those pathways, so to speak. Anti-PD-1 based doublets are absolutely the standard of care. In kidney cancer, you can add your favorite TKI to it. You can add CTLA-4 inhibition with some of the pros and cons I talked about. IO-VEGF regimens are more tumor shrinking and control up front. Ipi/Nivo maybe probably is more disease control in the back end, so pick what's important to you. I don't think single-agent TKI is the standard of care for any patient unless they have a contraindication because it doesn't cure patients. So even favorable risk, which can be very responsive, in my opinion, we can talk about this, they deserve IO-based therapy for cure. And again, we really need to do biomarker-based trial. We've done a terrible job of developing biomarkers in advanced kidney cancer. Hopefully our trial will be a step towards that and many other efforts as well. Thanks for your attention.